So we are going to start off Therapeutics 2 with humidity and bland aerosol therapy. Um, this therapy is very important to our patients. We want them to maintain adequate humidity in their airways because we don't want them to cause damage. We want to maintain normal physiological conditions. So that is why humidity is so important to us as respiratory therapists. So, in order to understand how humidity therapy works and why it's important, we are first going to go over the basics of how the upper airway works. So, the upper airway is the nose and the mouth. And the primary purpose of the upper airway is for heat and moisture exchange so that it is working when we are inhaling through our nose. It's going to add heat to that air and to add moisture and vapor to the gas that we are inhaling into our lungs. Because inspired air is variable in temperature and humidity. So, in order to compensate and to get the proper conditions, the body must add heat and moisture to it. So you need to know that heat and moisture exchange is the primary role of the upper airway. So the nose is heating it on inspiration, and then as we expire or we exhale through the nose, it's going to cool the nasal cavity. And through those turbinates in the nose, um, the heat and the moisture is going to go back into the nose. So on inspiration, the air is going to pick up that heat and that moisture from the nose. Now, on expiration, that heat and that moisture is going to be put back into the nose. So, our body has BTPS conditions or body temperature, pressure, and saturation. So, these are the conditions that must be met in order for the body to be having adequate humidification. So, the body's normal temperature. Always know your normals. Body's normal temperature is 37 degrees Celsius. The pressure that we're talking about is the barometric pressure. So obviously that is going to vary based on your location, whether you're at sea level or you're in the mile high city, barometric pressure is going to vary. And then saturation refers to saturation with water vapor. So a normal saturation would be 100% relative humidity at 37 degrees Celsius. So we're going to go over what relative humidity and absolute humidity mean. So if it's 100% saturated, it's 100% relative humidity at normal body temperature, it's going to have 44 milligrams of water vapor per liter of gas. So all of these conditions are being achieved as we inhale, and the lungs open up so that the air can go in. And so as we inhale, these conditions are all being met before they get to the lungs. So below the carina, about 5 centimeters below the carina, is the isothermic saturation boundary. And we are going to go over that in a few slides. So there's a lot of new terms on this slide, but we are going to break it down further. So we were talking about the nose and how it heats and humidifies gas. Now the mouth is much less effective than the nose at heating and humidifying, sorry. Take a second and think why this might be. So the mouth is less effective because first of all, it's bigger. There's not as much mucosal lining and vasculature in the mouth that allows for that heat and that humidity to be picked up. So here we have a picture of the nose. So we know that the nose's main job is to heat and humidify gas on inspiration. So during inspiration, turbulent flows are going to increase contact time between moist vascular mucosa and it's going to warm the gas through convection. So on inspiration, gas is going to come through the nose. Let's change it. Gas is going to come through the nose, and then turbulent flow. So remember, turbulence, it's going to kind of go all over the place. It's going to go through the turbinates, because if it were just a laminar flow, not as much gas would be in contact with the mucosa. So turbulent flow allows for more gas to be in contact with the mucosa, picking up water and warming up the air. So it warms gas through convection while also picking up that water vapor from the mucosal lining. And that's due to evaporation. So this causes the mucosal surface to cool. So on inspiration, it's like the gas is going to kind of steal that heat and that moisture from the mucosal lining. And then on expiration, gas is going to be cooled, and the mucosal lining is going to reclaim water from that expired gas. And it's going to also transfer that heat back to the now cooler mucosal through convection. And as the saturated gas cools, it's going to be able to hold less water vapor. So condensation is going to occur, and that moisture is going to go back into the mucosal lining and reabsorb in the mucus. So on inspiration, the gas is going to be heated and humidified, and then on expiration, the gas is going to be cooled and it's not going to be able to hold as much water vapor, and so the mucus is going to reclaim that water. So we are going to talk a little bit more about the ISB, or the isothermic boundary. So remember normal. So always know your normal. So normal isothermic boundaries is 5 centimeters below the carina. So picture, and we will see a little diagram here in a couple slides about the isothermic boundary. So above the isothermic boundary, the temperature and relative humidity of the gas is going to decrease during inspiration and increase during exhalation. So gas that's going into the lungs before it gets to the isothermic boundary is going to be decreased until it hits all those right conditions. So the air is not where it needs to be for the body to maintain homeostasis. Now, on expiration, because the air is coming from the lungs, it above the isothermic boundary during exhalation, that gas has a higher temperature and it has a higher amount of humidity in it before it gets to the nose. Below the isothermic boundary, the temperature and relative humidity will remain constant. There's nothing that is going to add to humidity. There's not as much vasculature. Everything, all the conditions are where they need to be in the lungs. So below the isothermic boundary, the air is where it needs to be. Now, this is under normal conditions. This is just normal inhalation, exhalation as we're breathing now. These are normal conditions. This is before we do anything that will shift the ISB. So the ISB can be shifted distally. Remember, distally means below, or it shifts it down. So the ISB is shifted down and further in the respiratory tract when a person breathes cold air, if the upper airway is bypassed, or minute ventilation is higher than normal. Humidity therapy may be indicated when there is a shift in ISB. Not always, but most of the time it will need to happen. This is because it is going to compromise the body's normal heat as well. So the body's normal temperature is 37 degrees. So if the ISB is shifted distally, the body's temperature, the air is not being humidified and heated up to the body's normal temperature. So gas is going further in the body at a cooler temperature, which can bring down the core temperature. So I am going to read some questions. I want you to write them down and then pause the lecture. Only take about 10 minutes to answer these questions, and I will give you the answers in a couple slides. So the first question is, describe why ISB shifts distally or shifts down for each of the following. If the person's breathing cold, dry air, if the airway is bypassed, and then if minute ventilation is higher than normal. So again, that question is, describe why ISB shifts distally for each of the following. A person breathing cold, dry air, the airway is bypassed, or an increase in minute ventilation. The second question is, what could cause the ISB to shift up? And explain. So we haven't talked about that yet, so I want you to kind of brainstorm what could shift the ISB up. And then number 3, what could prolong distal ISB shift due to the airways? What could prolonged distal ISB shift due to the airways? So from this slide, I want you to know what shifts the ISB distally. Okay, now that we've talked more about the isothermic boundary, let's go over relative humidity and absolute humidity. So relative humidity is a ratio, and it's the ratio between the amount of water in a volume of gas and then the maximum amount of volume that that gas can hold. So it's how much water a gas can hold versus how much it's actually holding. And it's important to know that it is represented as a percent. The only way that you can truly obtain what the actual relative humidity is by using a hygrometer, and that is going to measure the water vapor in the gas. So relative humidity can be obtained after using the hygrometer by taking the absolute humidity measurement and then using this equation. So you do absolute humidity or current, because that is what is in the water vapor that's in the gas this time. So absolute or current, and then you're going to divide it by the capacity. And remember, this will be a percentage, so it's going to be a ratio. So absolute humidity is the amount of water in that volume of gas at that given time. So it's the amount or capacity of water in that given gas at its current temperature. It also is measured by a hygrometer. So relative humidity, you're not measuring the relative humidity itself with this tool. You're measuring the absolute humidity and using that value to come up with your relative humidity. So it's expressed in milligrams per liter, and milligrams is going to be milligrams of water per liter of gas. So let's put these 3 things together, and visualizing them may make it easier to grasp these concepts. So we've gone over the ISB, which is here. You can see it up here, the isothermic boundary. So it's going to be about 5 centimeters below the carina. So it is right here. And then you have relative humidity, which is a percentage. And remember that relative humidity is how much water a gas can hold versus how much it's actually holding. So it's going to compare two things. And then absolute humidity, remember, is the amount of water that is in a gas at a given temperature. So looking at our picture here, at the beginning of a breath, so we are going to start the gas from the beginning of inspiration. So outside the body, before it goes into the nares, we have a temperature of, and this is just room temperature, of 22 degrees Celsius. And then we have a relative humidity at 50% and an absolute humidity of 10 milligrams per liter. So we know that with BTPS, for our body to have proper heat and humidity, that air needs to be at 37 degrees. The relative humidity should be at 100%. So before it goes into the nose, this is where it is at, and that is why the nose has the job that it has to heat and humidify the air that we are breathing. So once it goes into the nose, past the nose, so now we're in the oropharynx, headed down to the lungs. At this point in our bodies, the temperature of the gas is about 30 degrees Celsius. It has a relative humidity of 95% and an absolute humidity of 30 milligrams per liter. So also part of BTPS, remember, we want that air to have a capacity, so the whole overall capacity needs to be about 44 milligrams per liter. So we're not quite there yet, but we haven't hit the isothermic boundary. So once that air keeps going into the lungs and it hits the ISB, that is when our temperature is going to reach the 37 degrees. Our relative humidity is going to be 100%, and our absolute humidity is going to be 44 milligrams per liter. So the isothermic boundary is imperative to get the humidity and the heat that we need into the lungs. So another way to look at this is I like to think of it as buckets. So up here, when we're in the oropharynx, just outside the nose, we are going to say that this is that bucket. So we are at 30 degrees Celsius, and its capacity is 30 milligrams per liter. But once we get down here, past the isothermic boundary, our bucket is going to get bigger because it's now at 37 degrees and it's at 44 milligrams per liter. So as the temperature is going up, then the gas is able to grab and hold on to more humidity. So as the temperature goes up, the gas is able to hold on to more humidity. So as temperature increases, so we'll write this out. An increase in temp equals an increase in capacity. So how much it can hold, or absolute humidity. However, relative humidity always represents how much of that available capacity is saturated. So temperature is directly affecting the capacity, or absolute humidity. Temperature is not necessarily affecting relative humidity. So as gas goes through the body, absolute humidity and relative humidity are going to change. Okay, to add another key term, we have humidity deficit here. So humidity deficit is the difference from what the body has to make up. So it is the difference from where the gas enters the body and where it meets all the BTPS conditions. So you just take the absolute humidity and you minus it from the starting humidity, and that's the deficit. So the body has to make up 34 milligrams per liter of absolute humidity. So that's the deficit that the body has to overcome in order to adequately humidify and heat the gas. Okay, so now that we've gone through these terms, we're going to go over the answers to the questions that I asked earlier. So the first question was describe why the ISB was shifted down for each of the following. So we're going to start with the person breathing cold air. So if you think about you're in your house, you're at school, you're at work, and all of a sudden you walk outside when it's snowing and cold and freezing outside, and it kind of takes your breath away. The body is having to compensate for a bigger deficit. So the starting temperature and the humidity are lower than what they normally are. So the body has an even bigger deficit to compensate for. So the body is going to need more time to get to the BTPS conditions. That is going to cause a shift in the ISB to be lower in the airway. Now, if an airway is bypassed, so we're talking about endotracheal tubes and tracheostomies. So this one's a little easier. So the air doesn't have a chance to come in contact with any of the mucosa in the nasal passages because we are completely bypassing the upper airway. We are taking away the opportunity for the air to be naturally heated and humidified. So why would an increase in minute ventilation shift the ISB distally? That is because if somebody is breathing faster, there's a decrease in contact time between the gas they are breathing and the airway mucosa. So while they are still getting a little bit, it's going in faster and decreasing that time. Number 2, what could cause the ISB to shift up? So we know that shifting distally is going to be caused by things that decreases the gas or eliminates the gas from being in contact with the upper airway. So if the ISB is shifting up, it's going to be an opposite problem. There's going to be too much water vapor in the gas. So overhumidification and heat, and this is artificial, so this is what we add. So if we are overhumidifying our patient or adding too much heat to the patients and not meeting their needs or overcompensating for their needs, this is something we do. It can shift the BTPS conditions up. So it'll go above BTPS conditions and shift the ISB up. So this can happen if we are placing our patient on a heater and we set the heat setting too high, or if we are not using the proper humidification system and we are giving them too much. The ISB may also be shifted up if somebody gets too many fluids, IV fluids. Question number 3, what could prolong distal ISB shift due to the airways? So what can it cause to happen in the airways? So it can damage the airways. If there's a distal shift and air is not being humidified and heated adequately, it can dry out the patient and dry out their secretions. So they may have retained or insipated secretions that cause mucus plugging. and they may not be able to clear their secretions out, which can cause infections. It can damage the airways physically because that mucus has dried out. So having a shift for too long can damage the airways. Our last two key terms that we are going to go over are body humidity and humidity deficit. So body humidity is the relative humidity at body temperature, so 37 degrees. The capacity of water or absolute humidity at body temperature is going to be that 44 milligrams per liter. That is the max amount of humidity that's going to be in the gas in the body once it's hit the BTPS conditions. So to get body humidity, you take absolute humidity divided by 44 milligrams per liter times 100. So you are not going to need to calculate that. I just want you to know that the max amount um, of water that can be in a gas at body temperature is 44 milligrams per liter. So humidity deficit we touched on the last slide. So that is going to be uh, the difference between temperatures between um, the outside temperature of the gas and then when it hits the isothermic boundary. But it's not always going to be the same if BTPS conditions are not being met. So it is inspired air that is not fully saturated with body temperature. So the body has to correct this. So the humidity deficit will equal 44 milligrams um, is what you're going to use minus the absolute humidity. So if the humidity in the body has not met the temperature and it's not at 44 milligrams, you are going to subtract. So let's say that the gas is 75% saturated. So that means 25% of the gas is not saturated. So then you would take zero point 0.2, sorry, 0.25 times 44 because you know that is the max amount of capacity that the body can carry. And that is going to equal 11 milligrams per liter. So your absolute humidity, you know, is going to be 33 milligrams per liter. So then your body must make up the difference. So you know that our humidity deficit is going to be 11 milligrams. And if you don't already have the absolute, then you have it after this equation. So you know that 44 minus 11 is 33. So you know this is our absolute humidity, and this is going to be our humidity deficit. Okay, now that we have gone over why and how the body heats and humidifies the air that goes into it, we are going to start talking about the therapy itself. So the first thing that we're going to talk about is indications. So it's always important to know your indications for any type of therapy that you're going to give to a patient. The goal of humidification therapy is to maintain, remember, the normal physiological conditions in the lower airways. So by doing this, we are going to ensure that the normal function of the mucociliary tract is there. We're going to make sure that patients are able to cough up and move their secretions. We're going to make sure that they're not mucus plugging. So the goal of humidification therapy is to maintain those normal physiological conditions in the lower airways. So primary indications include humidifying dry medical gases. So we know that dry medical gases at flows of greater than 4 liters per minute to the upper airways can cause immediate heat and water loss. So if we know that it's doing that right away, if we leave it go for too long, it's going to cause structural damage to the epithelium. So what oxygen delivery devices can deliver flows equal to or greater than 4 liters per minute? All of them. So all of them can deliver 4 liters or greater. So we know that if a patient is on a nasal cannula and they're at 4 liters or greater, then you need to add humidification to it so that we're not causing damage to their upper airways. Now, if say they are on a simple mask or an oxy mask or a non-rebreather, we can't add humidity to it, but we can start to figure out what's going on with the patient. Why are they having such high oxygen needs so that we can fix that, so that we can decrease their oxygen rate, or we can get them moved on to non-invasive ventilation or some type of other ventilation that we are able to add heat and humidity to. So primary humidifying dry medical gases, bypassed upper airway. So anytime a patient has a trach or they have an endotracheal tube and we have to bypass their upper airway, we are going to add humidity for them and heat so that we are not causing damage to their lungs. Okay, so some secondary. So these aren't always going to be requiring humidity, but these are what you will see. So secondary indications. So hypothermia, that's going to help raise core body temperature. So it helps increase core body temperature. So with that humidity, you can do an aerosol mask, you can do a face tent, and we'll go over each of these adjuncts. And we are going to add heat to it to rise that core. Now, if they're hypothermic, you have to think there's going to be a larger humidity deficit because they've been breathing cold air. So their isothermic boundary is going to shift distally. So you're definitely going to need to add that heat to it as well. And then you have cool aerosol. With humidity, we're not always going to add heat. Cool mist is going to promote vasoconstriction. It's going to reduce edema because it's causing that vasoconstriction. So the capillaries in the airway are going to constrict and not be as leaky so that they don't have proteins and fluid moving in and out where they shouldn't be. So they're going to vasoconstrict, reduce edema, and it's going to help diminish upper airway obstruction by doing that. So cool aerosol is given for croup, epiglottitis, and post-extubation. All 3 of these have one thing in common: airway inflammation. So croup and epiglottitis, we are going to go over more when we get to pediatrics. Um, but so if you see something on a test or on an assignment, it will say croup or epiglottitis. I'm not going to give you signs and symptoms. I may say a barky cough, but since we haven't covered those quite yet, it will say croup or epiglottitis. Now, post extubations extubation is when we remove the endotracheal tube. Some signs and symptoms for that. So, stridor is a big one. And you can see stridor for epiglottitis as well. And stridor is going to come from it's going to come from the throat. It doesn't come from the lungs because the opening, the airway opening, the glottis is so inflamed that there's not as big of a lumen for the air to go out, so it's going to make a different noise. YouTube has some good examples. If you type in stridor, you can hear it. And a lot of times as you're walking up to rooms, you can hear the stridor happening. With post-extubations, if there's airway inflammation and they're needing cool mist and they have stridor, we're also going to give racemic epi. It's going to help vasoconstrict. You're also going to maybe see a look of panic if they feel like they're not getting big enough breaths. So just keep those things in mind. So we would add cool aerosol and that will help decrease the inflammation. Here we have some signs and symptoms that a patient has inadequate airway humidification. So these are what we're going to be looking for to guide us to know that we need to add humidity to their treatment, their oxygen, whatever the case may be. So the first one is atelectasis. So breath sounds that you might hear with atelectasis is fine inspiratory crackles. So fine inspiratory crackles. If you haven't listened to breath sounds before, fine inspiratory crackles um, sound similar to if you take a few strands of hair and put them in between your finger and then roll your fingers together. And that noise that the hairs rolling over each other makes kind of sounds like fine inspiratory crackles. On the chest x-ray, you might see consolidation. The next sign would be a dry, non-productive cough. So they don't have that humidity, that moisture in their lungs to thin out the secretions to get them up and out. The cough is not going to produce any phlegm or sputum. They may sound harsh, it may sound raspy when they talk. Those are all signs and symptoms. Increased airway resistance, or also known as raw. This is more commonly seen on the vent. So on the vent, you can do a calculation to measure the raw. So if they're not able to have that humidity and get the secretions out, it's going to increase airway resistance. There may be an increased rate of infection because they can't get their mucus out. Bacteria and viruses and microbes are more likely to be stuck in that thick, sticky mucus, and it can cause a pneumonia. It may show up in a sputum sample that is taken, so increased infection. They'll have an increased work of breathing. Their body is trying to compensate for that humidity that it is not getting. If they have secretions that are stuck in their lungs or maybe their mucus plugging, their body's going to have to work harder to get the oxygen that it needs. The patients may complain. So they may complain of substernal pain. So their chest feels tight, it just hurts to breathe. It's because their muscles, their accessory muscles, are working harder to get that oxygen, so they may be more sore. Patients may also complain of airway dryness. So that's a big one. Now, we talked about adding humidity to any gas flow greater than 4 liters a minute. If a patient is on a nasal cannula, say they're at 1, 2, 3 liters a minute, if they're complaining that their nose is dry or their throat is dry and they just are having a hard time with oxygen, it's okay to put them on humidity. It's not going to hurt them, it's going to make them feel better. So you can always add a bubbler, and we'll go over what that is and when to use it later in the lecture. But you can also add humidity to that 1 to 3 liters of oxygen if the patient's complaining. If they're not complaining, then you do not need to add it. If they have thick dehydrated secretions, so if their cough is productive and they just get this big glob out and you know they're on oxygen, but they had a really hard time coughing it up, you may want to add humidity to their gases. They can also retain secretions or have inspissated secretions. So that means they're stuck. Those secretions are just stuck in their lungs and they can't get them out. Humidity requirements at various sites of oxygen application. So if we are giving them oxygen at the nose or mouth, the body is going to require 50% relative humidity with an absolute humidity of 10 milligrams per liter on room air, at room air. So thinking back to that diagram that we looked at with the ISB and how relative and absolute humidity changes through the body. So if they're not receiving oxygen therapy, a normal person, just me and you sitting here breathing in and out, we have to have that 50% relative humidity coming in order for our nose to do the job, and start to heat and humidify that air. If we are adding increased gas flow, so if we put them on a nasal cannula at 4 liters per minute, and then the gas is going to be going too fast to fully absorb that water vapor and pick it up and that heat through the nose. So we'll need to make up for it so that they can have that 50%. If at the mid trachea, so if a patient has a trach, they're going to need 100% relative humidity with an absolute humidity of 36 to 40 milligrams per liter. And that is going to be at 31 to 35 degrees Celsius. So because we're bypassing the upper airway totally, we are going to have to add heat to that. We are going to have to add humidity to that. At the carina, so this would be endotracheal tubes, which you will often see abbreviated as ETT. So endotracheal tubes, we need to set the heat to 37 degrees Celsius. And because we needed that relative humidity up there at 100% on mid-trachea, it's going to stay the same here. But we are going to want an absolute humidity of 44 milligrams per liter. So we are going to have to compensate for all of their humidity and heat needs. With that being said, if we are delivering gas through an artificial airway, we can cause damage in minutes if we do not add heat and humidity. So we will damage the lower airway if we are not adding heat and humidity with an artificial airway. So humidification is mandatory with endotracheal tubes and trachs. So what we are going to need when we are doing humidity therapy is a humidifier. So the humidifier is a device that adds molecular water to gas. It's going to add molecular water to gas. And it does this because evaporation of the water from a surface is going to go into that gas. So it can be a reservoir, a wick, or a sphere of water in suspension. And we're going to talk about all of these in the upcoming slides. So whatever device you're using, that water is going to evaporate and go into the gas. So we can increase performance of a humidifier by modifying that humidifier. So with that in mind, what do you think could increase the humidity output of a humidifier? So I want you to pause this and try and write down a couple of things. So now that you have a list, there are 4 things that we can change and increase to make the humidifier work better. We can increase temperature, so temp, surface area, time of contact, and thermal mass. So we will go more in depth with what we increase to help increase humidity output. So temperature is our first one. This is the number one way to increase humidity output. So the higher the temperature of the gas, the more water it can hold. It's just like the natural flow of gas through the body, and as temperature increases inside the body, so does the amount of relative humidity and absolute humidity. So remember that temperature is the number one way to increase humidity output. And then you have surface area. So that's going to affect the rate of evaporation. So the greater the area, the more opportunity for evaporation. It's going to have the larger area. There's going to be more time to contact. It's going to have to go over more water. So as that water is evaporating into the gas, it's going to pick up more humidity. So you have passover humidifiers, bubble diffusion, and wicks. So these are all going to vary on surface area. So passover humidifiers gas, pass gas over a large surface area of water. So it pretty much, and we'll go over these individually. So we'll say that this is our humidifier, and this is our water. So the gas will come in through one side, and then it goes over the top of the water and out into the patient. So it passes over that water, and as the water is evaporating off the top, the gas is going to pick it up. And then you have bubble diffusion. So when I talk about bubblers, I'm talking about bubble diffusion. So it's going to direct a gas stream through a column of water, and it's going to push it under the water. So passovers will go on top of the water and the gas won't go through it. With bubble diffusion, gas is going to go through the water and create bubbles. And these smaller bubbles are what is going to cause more surface area. So small bubbles equal more surface area. As they are going up to the top to get delivered to the patient, it's picking up the water in those bubbles. And then you have wicks. So wicks use a porous absorbent material, and it's going to draw water in like a sponge. And it's going to be kind of like a honeycomb structure, so it's going to have capillary action. So it's creating more surface area in a smaller space for gas to flow through and pick up humidity. So time of contact is the next physical attribute that will increase humidity output. So evaporation will be increased as the gas contact time with the water is going to be increased. So the longer the contact time equals the greater opportunity for evaporation to occur. On your PowerPoint, it's formatted correctly. I don't know what happened with the downloading of this to this app so I can present it to you. So make sure that you refer to the PowerPoint on Blackboard. So bubble humidifiers. Contact time depends on the depth of the column. So you can see a small disposable bubbler here. This column is not as big as this column here. So there's going to be more time of contact with the deeper, bigger bubbler. So the deeper the column, the greater time of contact as bubbles rise to the surface. So it's going to take longer for those bubbles to get up to the surface before they get back to the patient. For passover and wick humidifiers, so I'll write this out since it's not on here, but it's on your PowerPoint on Blackboard. So flow rate of gas through the humidifier is inversely related to contact time. So basically what that's saying is if you increase flow with a passover wick humidifier, you're going to decrease contact time. So it's the same principle as increased minute ventilation on someone who's just breathing normally. So if you increase minute ventilation, that gas that passes through your nose isn't going to have as much time to pick up heat and humidity. So with a passover and wick humidifier, if you increase the flow on the flow meter, or if you increase the flow on the ventilator, you're going to decrease the amount of time that that gas has to pick up humidity. Again, on this slide, I am sorry for the wonky formatting. I will put the arrows where they are supposed to go. So thermal mass is the last thing that we can increase to increase humidity production. The larger amount of water in the humidifier leads to greater thermal mass, which leads to increased capacity to hold and transfer heat. So remember, if we increase heat, we're going to increase the humidity capacity. So we want to increase the heat also with thermal mass. So talking about bubblers. So bubblers that we looked at the last slide, and it's coming up on our next slide as well. So at the MBRC hospital, which I also call the Unicorn Hospital, states to replace bubblers when half full, as it is much less effective because it has a decreased thermal mass, because it has a decreased depth of bubbler column. So there's less water in the bubbler itself. So it's naturally decreasing that column of water, which is decreasing the contact time between the bubbles and the water. Now, in the hospital, in the real world, you're not always going to see that happen. If you go in, and you should be checking if your patient's on a bubbler or on bland aerosol therapy or they're on Passover, you're always going to want to check the water levels to make sure that you don't need to replace something. So the Unicorn Hospital says when it's half full, you're going to throw it away. Well, the hospital is also looking at cost. So if you still have a half full bubbler and it's still in good use, the patient has not had an increased need in humidity, then you are technically wasting money by throwing it away at half full. So anytime on the MBRC exam, the multiple choice exam, and you see one of the options is to replace a bubbler because you notice that it's half full, pick that one. So another side note, going through this class and as you continue through the program, we are going to say things like the MBRC hospital or the Unicorn Hospital. Their hospital is like the perfect hospital that has no complaints. They do everything a certain exact way and they're super precise. In the real hospitals, when you're out in the field, you're going to see the things vary. It doesn't mean that it's absolutely wrong and it's terrible and it makes people bad RTs or bad nurses if they don't do something that the MBRC says that they need to do. It's just reality versus perfect conditions. Okay, up to this point, we've gone over why humidity is important, when we would add humidity, and we know all our key phrases. So now we are going to move on with different types of humidifiers and when to choose those specific types. So we have two types of basic humidifiers. We have active humidifiers and we have passive humidifiers. Active humidifiers are going to heat and or water are going to actively be added to gas. So we can add heat and water, or we can add just water so that they're picking up water vapors through their gas, or we can just add heat. So bubble humidifiers, passover humidifiers, nebulizers of bland aerosols, and vaporizers are all considered active humidifiers. And then we have passive humidifiers. And what passive humidifiers do is recycle the heat and humidity from the patient's own breath, from their body. So they're recycling it from the patient. And the only passive humidifiers that we have are HMEs, which stands for heat moisture exchanger. Let's talk about bubble humidifiers. So these humidifiers are active humidifiers. And what happens with these humidifiers is gas is directed through the bubbler. So you can hear it called bubble humidifier or bubbler. So this here is a bubbler. So gas is directed here into a column of water. So the water is going to break up underwater into smaller bubbles. So it uses a foam or mesh diffuser. So that's going to force the gas to break up into smaller bubbles. And so in here in the yellow part where it hooks on the flow meter, the gas is going to have to go through a mesh diffuser. So that's allowing it to produce smaller bubbles. So a foam or mesh diffuser will allow it to produce smaller bubbles. Uh, Bubblers are usually unheated. They can be heated, but typically in the hospital, you're going to use disposable devices. Everything is disposable, so you don't have to worry about sanitizing it in between patients. So think about adding heat to a piece of plastic. What's going to happen? If it's not checked regularly, the plastic can melt, especially if it's closer to the end of the water use. It can deform the shape of it so it's not attaching right to the flow meter. So typically, bubblers are unheated. So in all bubblers, they are going to include a simple pressure relief valve, also called a pop-off valve. And what is going to happen is when it has some sort of obstruction at 2 psi or greater, it's going to kind of alarm. So it's going to make this high-pitched squealing noise, and it's very loud, but it's going to let you know that the oxygen is occluded. So this is going to help not only prevent the patient going without oxygen if the oxygen tubing is occluded, but it's also going to help prevent the bottle from bursting because of that occlusion. So I want you to know that it will alarm, that's terrible, sorry, at greater than or equal to 2 psi when it is occluded. So think for a minute, how might a nasal cannula become occluded? So it can be occluded by condensation. So if there's too much water in the bubbler and there's droplets, or if the bubbler is heated and there's condensation, because as the gas travels away from heat, it's going to cool down and cause condensation in the tubing. So it can be occluded through water, mucus, or it can be kinked. Maybe they're sitting up in a chair and the chair rolls over the oxygen tubing. Bubblers can produce aerosols at higher flow rates. So aerosol is different from just humidity. Humidity is going to be that water vapor in a gas. Aerosol creates bigger water particles within the gas. So the higher the flow rate, the more likely that the bubbler is going to produce aerosols and bigger water droplets. So that poses a risk for infections because bacteria likes to live in um, warm, wet conditions. So there's more chance of bacterial colonization. So anytime you hear aerosols, think increased infection risk. So when a nasal cannula is placed at a liter flow of 4 liters or greater per minute, you should always have humidity. So nasal cannula at 4 liters per minute or greater, you need to add humidity. If your patient is complaining of nasal dryness or airway dryness, you can always add a bubbler at liter flows less than 4 liters, but it's not required. So if your patient, for example, they're in the hospital and they're on 1 liter nasal cannula and they're complaining that their nose feels really dry and it hurts and they don't want to leave the oxygen in, you can add a bubbler and it's okay. But if they are in the hospital and they are at 2 or 3 liters and they're not complaining of nasal dryness and they don't have a problem with the oxygen, you can leave them off of the humidity. So as gas flow increases, the reservoir can cool by up to 10 degrees, which limits the effectiveness of bubblers if they run greater than 10 liters per minute. So this is why they have special types of bubblers, and we're going to see a picture in just a minute, that will allow flow rates to go up to 15 liters per minute without having to have that risk of aerosols and cool the air too much. So a couple review questions. What would happen if I had a patient on a nasal cannula with a bubbler and the tubing gets kinked? So the pressure relief valve would initiate when the pressure exceeds 2 psi, because that's meaning though that patient is not getting any oxygen. So we need to fix that as quickly as possible. If you hear the pop-off valve, what should you do? So you should check for kinks or occlusions. What type of patient would a bubbler work best for? So this would work best for patients who are requiring delivery of a medical gas to the nose via nasal cannula at 4 liters per minute or greater. So here we have a couple pictures of nasal cannula bubblers. So you can see this is a sagittal view. So the dry gas goes in through this tubing, and then this here is going to contain the foam or mesh diffuser, and this is going to break up the gas into smaller bubbles, and that increases the surface area to allow the gas to pick up water vapor as it goes back up. So when it gets up out of the water, then that gas is going to go to the patient. This is the pressure relief valve, and this is an example without heat. Here's an example with heat. So the heater can either go underneath or sometimes they're on top, and that's called either a collar or a yoke heater. Now, most are designed for low flow systems and not heated. There are special bubblers, and depending on what hospital you're at, their policies and protocols are going to be different. For example, at St. Anthony's, once a patient got above 6 liters per minute while they were on the floors, that's when we'd start to call doctors. We'd start to call a rapid response if all of a sudden their oxygen needs changed, because at 6 liters per minute, they can no longer be on the floor. They need a higher acuity of care. So whether it's a step down unit or an ICU. So these are going to be mostly for low flow and not heated. Now, what happens if we heat the humidifier? So if we add heat to a humidifier, we're going to increase that absolute humidity, which is going to increase the humidity output. If a heated humidifier is attached to a nasal cannula, what problems could arise? So if we have a heated humidifier, we can have condensation, which can lead to obstruction, which means no oxygen is getting to the patient, or if it's enough oxygen, we risk spraying the patient in the face. And like we said, that bacteria likes to live in water. So if we have bacteria in that condensation, and then we are getting it into the patient, we're risking aspiration and further infection. So when humidity is required for a patient with higher flows or artificial airways, instead of using oxygen tubing, we're going to want to use what's called corrugated tubing. And that is used to decrease the risk of infection. And then a drain bag is placed at the lowest point so that that condensation is easily collected and we can remove it and we are not risking the patient. And we will see pictures of those later on in this lecture. The pass-over humidifier directs gas over the surface of the water. And there are three types. You have the simple reservoir, and you're typically going to see that on CPAP machines and vents. So it's like the name says, the gas simply passes over the water chamber to pick up heat and humidity. Then you have the wick humidifier, and that's a cylinder of absorbent material, and it may be a honeycomb shaped. All brands are going to be a little bit different, but that absorbent material is going to increase the surface area to help produce more humidity. That cylinder of material is surrounded by a heating element. So the water is drawn up into the wick via capillary action, and then it's going to go through the wick and that increased surface area to pick up the heat and humidity. With these, there is no bubbling. If there is no bubbling, then there's no aerosol. So there's a decreased risk of infection because there's no aerosol. The third type of passover humidifier is a membrane. So this is what you're going to see on a vapotherm. I'll write that out so you can spell it. So a vapotherm, and that's a heated high flow nasal cannula, which we will learn about during non-invasive ventilation. So the vapotherm is typically used for infants and premature infants. They can provide CPAP and have higher oxygen flows, but they need a special type of humidifier so that the air that's going faster can be heated and humidified accurately. So a membrane humidifier is going to use a hydrophobic membrane, so that membrane doesn't like water. And that membrane is going to separate the gas and water reservoirs. So as the gas goes by it, water vapor can pass through the membrane, but liquid and pathogens cannot. So a membrane is a hydrophobic membrane that separates the gas and water, and the water vapor can pass through that membrane, but liquid and pathogens cannot. So the advantages to these type of humidifiers over the bubbler is that it can adequately heat and humidify gases at a higher flow rate. It's not going to add any flow resistance, and if it does, it's very little. It's not generating aerosols, and aerosols can also add to airway resistance and flow resistance, so the patient isn't getting adequate not only heat and humidity, but also they're not getting the proper FiO2. And then they do not generate any aerosols that can spread infection. So here we have the humidifiers that we've talked about so far. So we have the bubble humidifier that we went over. The gas would come in here, and this diffuser of mesh or foam breaks it up into bubbles, so it goes under the water and comes back up to the patient. We are going to go over large volume nebulizers and aerosol nebulizers in a little bit. So here we have passovers. So the gas is directed here, and it doesn't go under the water, it just goes over the surface, and it is picking up the heat and humidity through evaporation here, and it simply goes out. Now the other two type of passover humidifiers that we just talked about was the wick. So these would be little cylinders of wick absorbent materials, so that airflow is increasing surface area. So as it's going through the material, it's picking up more humidity, and then it goes out to the patient. And then the membrane, so here's the membrane, the blue. So our water's on this side and our gas is on this side. The water cannot cross the membrane, only water vapor, and then it goes out to the patient. So let's practice a little bit of what we learned so far. So let's take a couple patients. So let's say our first patient, his name is Snotty Smith, and he is a 54-year-old male who is on mechanical ventilation. What type of humidifier would you use for him? So the best choice for Snotty Smith is going to be a Passover, and or wick humidifier. So either one of those would be correct. Number 2, say we have Sally Smalls. She is a 22-year-old female, and she is on 2 liters nasal cannula, and she is not complaining of dryness. So because she's not complaining of dryness, she would not need any humidification, because the key here is she's on 2 liters nasal cannula and not complaining of dryness. Number 3, Billy Blue. He is a premature infant, and he's on high flow nasal cannula. What type of humidity would you use? What type of humidifier? So for Billy Blue, premature infant, and we know he's on heated high flow. So we would put him on a membrane. Number 4, Jenny Jones is a 39-year-old female, and she's on 5 liters nasal cannula. So for Jenny, we would put her on a bubbler. Heat moisture exchangers, also known as HMEs, are passive humidifiers. So if you can remember that these are passive, then you'll know the rest of our humidification devices are active. So heat moisture exchangers are also known as the artificial nose. That's because they capture exhaled heat and moisture from the patient and recycle it with every inspiration and expiration. So it's recycling their own heat and humidity to keep the air that they are breathing heated and humidified. So this is indicated for short-term mechanically ventilated patients. The key phrase is short-term. So anytime they are going to be on the ventilator for 96 hours or less. So know that. So this is used for transport. So when we take them off the ventilator in their room at the bedside and we put them onto a smaller ventilator to go to the OR, we can be taking them to get a CT scan. We can be taking them to radiology or other procedures. So HMEs can be used if they're post-op. So if the surgeon does the surgery and they think they're going to be off the ventilator shortly, but they just need to wake up a little more from sedation and paralytics, whatever the case may be, they can be on HMEs instead of having to break the circuit, which are the tubes that go to the endotracheal tube from the vent, and switching them over again, we can use an HME. So it is contraindicated for patients with excessive secretions, extra thick secretions, if they have very large tidal volumes, or if they have hypothermia, because then their core body temperature is low anyway, if they're hypothermic. And so we want to add that heat to help bring their core temperature up. So always know your contraindications and your indications. This is going to add 30 to 90 mLs of dead space. So is there a patient population that you can think of that this dead space would be an issue or make a difference? So 30 to 90 mLs of dead space, yes, would affect infants because infants, 30 to 90 mLs is the tidal volume of an infant. Plus, on top of that, they are using an uncuffed endotracheal tube, and that is going to allow air to bypass the HME. So not only are we adding dead space, but it's also going to bypass that HME as well. So it's not going to work. So it is contraindicated for infants or smaller tidal volumes and uncuffed ET tubes as well. So if you walk into a patient's room, say you're doing a ventilator assessment and you're going to assess the patient, and you notice that the HME is clogged with secretions, you should throw it away and switch to heated humidity because chances are that you are going to walk in again and the next HME is just going to be clogged with secretions. Never try to rinse out the HME. Throw it away and change them to heated humidity. So use a Passover or a wick humidifier. The HME needs to be placed between the Y and the patient on the vent. So you'll have to excuse my drawing, it's not great. So what a patient Y looks like. So if we have our corrugated tubing, let me erase that. So if we have our corrugated tubing here, so we're going to say that this is a ventilator circuit. So this part right here is considered the Y. So you can see how it's a Y shape. So one side is going to be the inspiratory circuit and one side is going to be the expiratory circuit. So you want to place your HME somewhere here because it's between the Y, and then this will go to the patient's endotracheal tube. So if you're having to give a patient medication by neb or MDI while they're on the vent and they have an HME, you should remove the HME because it can filter out the medication. So there are three types of HMEs. You have the simple condenser, which contains a condenser element with high thermal conductivity. So inspired air will cool the condenser. On exhalation, water vapor condenses on the element and warms it, and then it is recaptures the moisture and heat on the next inhalation. Then you have the hygroscopic condenser, and this is going to use a condensing element of low conductivity. So with that condensing element, there's hygroscopic salt inside of the element. So on exhalation, water molecules bind to the condenser directly to that salt. On inhalation, the particles are liberated from that salt due to the lower water content of inspired air. And then you have hydrophobic condenser. And this is going to use a water repellent element with high surface area and low thermal conductivity. Keep in mind that with any HME, it's going to increase flow resistance after several hours because water and moisture is being trapped in the filter and it's going to absorb more. So it's going to cause an increase in flow resistance, and that's why this is for short-term use only. So from this slide, I want you to know that there are three types of HMEs and that HMEs will increase flow resistance. With many of our humidifiers, we're going to add heat. So heat improves water output um, of, I should say of, bubble and passover humidifiers. Although we've talked about it, we typically only use it for passover humidifiers, and it's very rare that we use them on bubblers. They're primarily used for patients with a bypassed upper airway, so patients with a trach or patients who are on mechanical ventilation with an endotracheal tube. We do risk airway burns if the temperature becomes too hot or if a RT or nursing is not paying attention and the humidifier runs out of water and that air is just dry and hot. And we increase risk of infections because we're adding heat and water. And if we get condensation in the tubing, then we risk that bacteria colonizing and getting into the airway and causing further infections. So we always, always, always use heated humidity on patients who are mechanically ventilated because we are breathing for them. We are totally bypassing their upper airway, and we want to maintain those normal physiological conditions in the lungs. Now, with heaters, we will auto set alarms to plus or minus 2 degrees Celsius so that we know we are giving them adequate temperatures. So we have different humidifiers. We also have different heat sources. So we have hot plates, and that is typically on a passover humidifier. And that's going to be a simple passover humidifier. This here would be a hot plate. You can see that there's just this silver piece here. That is our hot plate. This hot plate. This blue piece comes down and the passover humidifier sits on top. So that's our heating element. We have this in the lab, so I will show it to you and we will go over it in the lab. We have a wraparound heater that we can use, and that's what we're going to use for our wick. We have a yoke or a collar, and that's going to be this guy here. And this is typically used on aerosol collars. We have immersion heaters, and that's when the heater is put into the water reservoir. And then we have heated wire, and that's going to be inside the patient circuit. There are two types of system. The first system is a simple system, and that the controller or the base is going to monitor the heating element itself. And then you have the servo controlled, and that's going to be a bigger system, and that's going to monitor temperature at or near the patient's airway using a probe. And then it can control and adjust the heater to achieve the desired airway temperature. So this bottom one is going to monitor. If you can zoom in on your PowerPoint, you can see a little picture and it'll light up and tell you where the heat is alarming, if it's too hot, if it's not receiving heat at all. So you can tell that here. So this Fisher Paykel would actually changes and adjusts temperature to control at the patient's airway. So both of them have alarms, both the simple systems and the servo controlled. They both have alarms and alarm activated shutdown. So if it gets too hot, it's going to shut it down to decrease the risk of airway burns. In order to give our patients on mechanical ventilation and non-invasive ventilation the humidity that they need, we use reservoir and feed systems. And this is used to avoid constant refilling by these two systems. So a large reservoir is also known as a manual system, and these are used with ventilation, but instead of hanging a bag of inhalation sterile water or a container of sterile water, the RT is responsible for refilling that large reservoir. The problem with that is it can alter temperature by waiting until that large reservoir is lower in volume and adding water to it. It's going to cool down and not heat up as fast, so it can alter the temperature. It interrupts mechanical ventilation because the way that the circuit is above the humidifier, you have to take off the circuit to the ventilator, fill the reservoir, and then put the circuit back on. And then when we do that, we can increase the risk of infection to the patient, not only from disconnecting the ventilator, but by adding, even if we're adding that sterile water, we are exposing the reservoir of that humidifier to the open air and pathogens. So our biggest risk of infection, what happens is it costs the hospital money. If a patient gets what's called a VAP, or a ventilator associated pneumonia, or a ventilator associated infection, their insurance company, whether it's private insurance or Medicare, will not reimburse the hospital for any treatment after they get hospital acquired infection. So it's going to cost money. It can also kill the patient. If there's a pathogen and the patient gets a pneumonia and they are unable to fight off that infection, it can kill the patient. Now, with a gravity-fed system, there is a small inlet added to a reservoir. So the picture on this slide would be an automatic or a gravity-fed system. So they have an inlet, and there's a video of this specific humidifier. It's the Neptune that comes in through here, and it's a wick humidifier, so it goes through a column inside the humidifier itself. And there's a inlet here and one here. And so it goes through the humidifier. So when you are changing this here, you're not disconnecting the patient circuit because that's attached also up here to the top of the humidifier. So you are not having to interrupt ventilation to change out the gravity fed system. So these are not going to pose an infection risk. So that small inlet is added to the reservoir, and a gravity fed water bag or a container such as this allows refilling without interruption of ventilation. And it's not going to change the heat. It's not going to cool down that water vapor. They do require constant checking to make sure that there is an adequate amount of water between the time that you're seeing them now to the next time you come to do a ventilator assessment. If you are not checking these systems, they can go dry, the humidifier can go dry, and then that would put the patient at risk for airway burns and airway damage. Because remember, having a patient on a ventilator without humidification can do airway damage within minutes. When we are setting up a humidifier, we need to make sure that they are on the adequate humidification settings. So they need to provide the optimal levels of humidity, which is at least 30 milligrams per liter for intubated patients, and airway temperatures near 35 to 37 degrees Celsius, so normal body temperature. Gas should not be greater than 40 degrees Celsius because that can cause airway burns. If temperatures rise above 40 degrees Celsius, the alarm should sound on the heater itself in the humidifier, and then power will be cut off. Most modern humidifiers automatically have this feature. So on many humidifiers, and we'll look at this in the lab as well, there is an invasive setting and a non-invasive setting because that is going to differ for temperatures. So on invasive, it's going to be 35 to 37 degrees Celsius, and then non-invasive will be 30 to 32 degrees Celsius. We are going to go over some problem solving and troubleshooting that you may see with humidifiers. Problem solving and troubleshooting is something that you need to be able to do with any type of treatment, like with when we talked about bubble humidifiers and you hear the pop-off valve, what should you be looking for? So it may be something as simple as a kinked oxygen tubing for a bubbler. So we are going to go over the heated humidifiers now. One of the biggest problems with heated humidity is condensation. So it poses a risk to caregivers and patients, and that is of infection. Anytime that you have condensation or aerosol particles and you risk that bacteria colonizing, you are risking an infection to the patients. But if you have to break the circuit and change the circuit, or you're breaking the circuit to put in a nebulizer in line, then you risk posing a threat of infection to yourself as well. It wastes water. It occludes gas flow through the circuit, so your patient's not getting the proper flow or the proper FiO2. It can be aspirated. So once a patient is receiving humidification and they have a closed circuit and they're breathing, it within hours the water is considered infectious waste because it has everything that they're breathing in and out, and what is growing in their lungs is going to be in that humidity. So it's considered infectious waste. It can alter their FiO2, their vent function, or both of them. When you get to IMV, Justin will talk about flows and pressures and airway resistance and how that can be altered. So this problem can be minimized with the use of water traps or heated circuits. So water traps are going to be placed at the lowest point on the circuit so that it doesn't go back to the patient. Heated circuits have wires throughout the entire circuit that is going to keep that gas the same temperature it was when it left the humidifier until it goes to the patient. So the question says, with heated humidifiers, what happens as the gas travels through the circuit and to the patient? So if we have a normal circuit that doesn't have those heated wires, after it leaves the humidifier, that gas is going to start cooling, which is going to decrease vapor capacity, which is going to cause condensation or rainout. If you have a heated circuit, do you need a drain bag? No, you wouldn't need a drain bag because that gas's temperature is being maintained all the way through the circuit. Okay, so take a second to look at this picture. We'll go through it real quick. So gas source, so this is the ventilator. So this is going to be what's called the inspiratory limb. So it's going to come from the ventilator machine. It's going to go through the humidifier. It's a pass-over humidifier. It's going to pass over and get the humidity, go up and out and towards the patient. And this is the patient Y that I was talking about. So the Y is here. So it's going to go to the patient through the ET tube in their lungs, and then on exhalation, it's going to come out through the expiratory limb. So looking at this picture, if the patient were here, because the Y is here, so we're going to say the patient in their bed is down here. If there were a patient at the end of the illustration, what could go wrong? So if you look at the arrows, the patient is positioned downward of the condensate. We don't see any heater wires. We see the heater here, but there's no wires. We're going to assume that it doesn't have wires in it. So the condensation is going to travel down to the patient. So it's going to drain directly into the patient's airway. So when you have a patient who has a circuit that is not containing heated wires, the circuit must be placed to drain the condensate away from the patient. We can also place water traps at low points in the circuit, and that's going to allow for emptying without interruption of ventilation. So you can drain those traps without having to take the circuit away from the patient. So let's say that I need to give the patient a nebulizer treatment, and I don't change the circuit, and I just put the neb cup right here. And it's medications in there. So that I have the neb cup. So if I'm giving this neb treatment and I left it like this, what would happen? So if I left it like this, the neb cup becomes an unintentional water trap because it's going downward to the patient and it's going to trap the water, the condensate, into that neb cup. So one way that we can prevent this is by adding circuits that have heated wires. And that's going to prevent that gas from cooling in the circuit um, going back to the patient. So the controller, so the heater itself, and then there's probes, remember, so that are attached to that controller near the patient's airway are going to monitor the temperature. So these are the most accepted and sought after um, equipment to use in the ICUs because it's going to help with rainout and decrease the rate of infections. Why wouldn't heated circuits be used in every hospital across the country? So they wouldn't be used everywhere because they're expensive. The cost is expensive. You may have hospitals in Denver that have larger budgets, they have more advanced equipment, but then you go off further into rural areas, those hospitals are just smaller. They may not have as many ICU patients. They may just ventilate patients until they can be transported. So they're expensive and everything expires. So if they're not using them, then they're wasting their money on these expensive pieces of equipment that aren't having a great amount of use. So here we have a couple examples um, of what to do. So here we have a Passover humidifier, and these are heated wire circuits. You can see a probe goes here, so it's near the airway, so that the controller can monitor the temperature at the airway. And here you would put the other temp probe so that it can monitor when it's leaving the humidifier what the temperature is to make sure that the heating wires are working. In the second picture, you can see that the neb cup is placed in line with the ventilator circuit, but see how the inspiratory limb is going down so that even if there is rainout with heated wire circuits, it can happen um, depending on the patient's minute ventilation, the temperature of the room, and if there's an increased flow. So what I want you to know is that this is not becoming an unintentional water trap because the circuit is going down. It's not going to go back to the patient or into the nebulizer cup. Infection is another big problem that we can see with humidity therapy. So we want to try and minimize condensation. So remember, we can do that with heated circuit wires. And then, like this picture, we can add water traps. So these would be water traps in a circuit that need to be at the lowest point of a patient's circuit to prevent it from being fed back directly into their airways. So we can minimize condensation. We can also use a wick or membrane Passover humidifier to help that prevention of formation of aerosols. And we also want to decrease ventilator circuit changes. I mentioned earlier that the more we break the circuit, the more risk we have of VAP, a ventilator acquired pneumonia. So we want to try and break the circuit as least amount of times as possible. We also want to avoid products that produce aerosol for ventilated patients. So we basically want to heat and humidify the air and keep that water vapor in the gas going from the humidifier to the patient and avoid condensation altogether. Now we're going to move on to other therapies that are done with humidity for specific indications. Bland aerosol therapy is a type of humidity where it's not water vapor, it's consists of liquid particles that are suspended in a gas. So water vapor is smaller and it's not going to cause those droplets, whereas bland aerosol therapy is like it says, it's aerosol, it's liquid particles suspended in a gas, and we can use oxygen or air for this therapy. So the liquids that we use are sterile water or sterile saline. And sterile saline we can do hypotonic, we can do isotonic, or we can do hypertonic. So hypotonic is going to be less salinity than that of the body's natural salinity. So we'll write that right here, less than body's normal saline. We have isotonic, so that's going to be normal saline, so that's 0.9%. So normal saline. And then you have hypertonic. So that's going to be greater than 3% saline. And this is what is used for sputum samples. And it's also used by patients with cystic fibrosis. So if you see tonic, tonic equals salt. So the difference between humidity and aerosol is, remember, humidity is water in the gas phase and aerosol is liquid particles suspended in gas. Bland aerosol therapy indications, so always know your indications. So bland aerosol therapy can often be called cool mist or cool bland aerosol. They are all interchangeable. So we have upper airway edema, laryngeotracheobronchitis or croup, subglottic edema, and post-extubation edema all have to do with inflammation. So remember, cool mist is going to help promote vasoconstriction and decrease the swelling in those airways. So this is a picture here of some subglottic edema or post-extubation edema, and you can tell that airway is compromised by this swelling. So you want to make sure that you are getting cool mist aerosol because heat is going to help the vasculature open up, and we don't want further swelling or inflammation. We want cool mist to help promote that constriction. So croup, if you haven't heard of it, is an upper airway infection. It usually occurs in children, but it's going to block breathing because of inflammation that also leads to an accumulation of mucus. Croup has a distinctive barking sounding cough. We also use bland aerosol therapy for post-operative management of an upper airway, a tracheostomy for patients who are not being mechanically ventilated, and for sputum induction. So a sputum induction is a process where hypertonic saline is nebulized in attempts to acquire a sputum sample. So why would sputum samples be useful clinically? So we obtain sputum samples to diagnose respiratory infections. So remember, sputum is mucus that passes through the mouth. So if we get a sputum sample from someone on a vent, we're getting a mucus sample because we're going to get it directly through suctioning through their lungs. Whereas if we have a patient who's up and awake and able to be nebulized and cough it out, it's going to be considered sputum. Large volume nebs are the most common device that are used for bland aerosol therapy. They are pneumatically powered, so remember that means pneumatically means they're powered by gas. An unheated large volume neb can produce 23 to 35 milligrams of water per liter, whereas heated large volume nebs can produce 35 to 55 milligrams of water per liter. So why do heated generators produce more milligrams of water per liter of gas? So it's not that they generate more particles, but instead they're increasing the vapor capacity of the gas. So the gas is able to carry more humidity when it is heated. Now, adding a heater to a large volume nebulizer, while beneficial, it can cause problems because that heater is only going to control itself. It's not going to measure the patient airway temperatures, and it's not going to have those alarms. It's not going to be able to shut it down if it gets too hot. So it can dry out the patient, it can do damage to the large volume nebulizer itself, or it can cause airway burns. The large volume neb also has a variable air entrainment port, so it's very much like a Venturi mask where you can dial in the FiO2. So here you see that they are placing it on oxygen. And then this here, and we'll go over this in the lab, this here you can see is where you would set your FiO2, and when you set your FiO2, it'll also tell you what liter flow to put the flow meter at. So how the large volume nebulizer works is the gas leaves a flow meter. It's going to go at a high velocity through this jet here. It's going to go into the nebulizer. That low pressure jet is going to draw fluid from the reservoir tip, so it's going to come up here, up the siphon tube, and then it's going to shatter the water into liquid particles, and that gas is going to go into those liquid particles, and the smaller particles are going to leave the nebulizer to the outlet port and to the patient. With these particles are the particles that are being generated monodisperse or heterodisperse. So these particles would be heterodispersed because they are all different sizes. The nebulizer isn't going to make one size of particle. Here we have a few pictures of different kinds of large volume nebs. So this first one is called a Mistiox, and you can read about it in your White's equipment therapy book. So this is going to be a high flow. So this is going to be for patients who need a higher flow demand that can create aerosols. These are your typical large volume nebs that you're going to see. It's typically not with a bubbler, so they're going to be the larger bottles. And these are both disposable, both the Mistiox and this. And then this over here would be an example of a heated large volume neb. And if you look at the controls here, you can set it for on and off and then your temperature. And it's not going to control anything at the patient's airway, and there's no alarm here. Now we will go over the different airway appliances that are used with cool mist and bland aerosol therapy. So you need to know the types and when they are used and what they are used for. So the aerosol mask. This will be used for nebs if a patient can't use the handheld nebulizer with a mouthpiece, and it's also used for cool mist aerosol. Then we have the face tent. This will be used post-extubation and if a patient can't tolerate the aerosol mask. Some patients feel claustrophobic in the aerosol mask, and the face tent is more open, so they tolerate that better. The T-piece, it's also known as the Briggs adapter. This is used for patients who are weaning from the ventilator with a tracheostomy, and then for cool mist or humidification for tracheostomies. And then we have a tracheostomy mask, which is also known as a trach collar or a trach mask. And this is for use for bland aerosol therapy for trachs. All of these are used with large bore corrugated tubing, which is this picture here. So it's usually blue. You'll have two sides with one that's connecting to the patient and the drain bag, and then the second piece is connected from the drain bag to the large volume nib. And remember, you want to keep that drain bag at the lowest point so that the condensate drains into the drain bag rather than going back to the patient. So the corrugates, these little ridges here, trap some of the condensate, which allows for a smoother flow of the gas, and the large size prevents small amounts of water becoming a big problem, because if we get condensate in oxygen tubing, it's a smaller diameter, so it occludes the tubing faster. This large bore tubing is going to prevent that from happening. Here we have pictures of each. So this first one is the aerosol mask. I'll write these out. So this is an aerosol mask. Make sure that you are not calling it a simple mask because it's got a different connection on the front. So it's going to connect to that large bore tubing here, and it's got larger holes than the simple mask does. So you're going to have to be able to identify these on exams, so make sure you know what they look like. So the aerosol mask, and then we have the trach mask. And then we have the T-piece. And then we have the face tent. So the aerosol mask and the face tent are for patients who have intact upper airways, and the trach mask and T-piece are for tracheostomies. And the T-piece can also be attached to an endotracheal tube for weaning. So those would be for artificial airways. Enclosures include mist tents and hoods. These are used for delivery of aerosol therapy to infants and children because infants and small children may not tolerate those direct airway devices like masks. They'll pull them off. They won't use the therapy. So this is easier. So enclosures and a hood may be a solution if you have a kiddo who's not tolerating them. Tents are usually used to treat croup, but these do pose some possible problems. So heat retention. So you have them in an enclosure, there's not as much airflow through there, so they can heat up faster. There can also be CO2 buildup in tents, so you want to make sure that if you're using these, that you read the manufacturer information so that you have the proper flow settings. Sputum inductions are another therapy that we use. Remember, it's biggest tool for diagnosing respiratory infections. It's cost effective because we're using hyper or hypotonic saline, which is not going to cost as much as other medications. Um, it's used for diagnosing infections, and it's a short-term nebulizer. It's not going to be ordered Q4 or QID. It's usually done once to try and get the sample and send it to the lab and get it back. And then it may be done again to see if the antibiotics are working or if your patient has a change in status. They could see if they're growing something else. So we are going to use hypertonic saline in a short-term application. Typically, we use 3 to 10% salinity. It's also used for mucociliary clearance because it's going to help hydrate and thin secretions. It's most common in our cystic fibrosis patients. It's also going to encourage a cough if we're using hypertonic saline because that's an increased salinity compared to the body. So it's going to kind of irritate those airways and encourage somebody to cough. So, some problems we might run into with bland aerosol therapy infections. We have those larger particles where bacteria likes to grow being produced. So, infection is really a big enemy of healthcare in general. So, we want to try and prevent this whenever possible. So, we want to adhere to our hospital's protocols, the CDC guidelines, JCO guidelines to prevent infections. Environmental exposure. So, this is going to be both for the patients and us as care providers because we are mostly concerned with aerosol therapy that is being provided to an immunosuppressed patient, or if they're at a hospital where they have to share rooms and they're immunosuppressed and someone else in the room is receiving an aerosol treatment. Or with patients who have an active or suspected infectious disease, such as TB. The biggest one right now is COVID. And giving these COVID patients aerosol therapies, we need to be protecting ourselves as well as those around us and those patients. Um, s- Another one is when we are giving ribavirin to a patient, clinicians need to be very cautious of secondhand exposure to that drug. Inadequate mist production is another problem we can see. So that's actually a problem with all humidification systems. So we need to be able to troubleshoot our large volume neb, our passover humidifier, our bubbler to make sure that they are getting the proper flows and the proper humidification. So with pneumatically powered large volume nebs, it can be caused by an inadequate input of flow that is driving the gas into the nebulizer. So you want to check and make sure that the flow setting is on properly and that there are no loose connections. Overhydration is another problem with bland aerosol therapy. This is more commonly seen in ultrasonic nebulizers, which we will go over when we talk about aerosolized medication. Um, but if we accidentally overhydrate a patient, how would the ISB shift? So the ISB would shift up because it's not going to take as long for the gas to hit those ISB conditions, the BTPS conditions. Bronchospasm is something else we can run into with bland aerosol therapy, especially if we're using hypo or hypertonic saline. And then noise. Large volume nebs, once we get in the lab, you'll hear how loud they can get, especially if we're using a higher flow. And with infants, it's going to be more common, and that can cause stress to the infants, which can be dangerous. So it's something that you need to be aware of and keeping an eye out for. So our last slide in this lecture is a clinical challenge. So after abdominal surgery, a 50-year-old man is brought to the recovery room and started on an aerosol mask at an FiO2 of 50%. While performing your initial assessment of this patient, you notice that his respiratory rate is 20 breaths per minute and he shows signs of respiratory distress. You also note that on inspiration, the aerosol stops flowing from the mask. How would you remedy this situation to ensure the patient is receiving 50% oxygen? So let's kind of dissect this. So you know he's on 50%, and his respiratory rate is still technically within normal limits, but he's showing signs of respiratory distress. And then you also notice that aerosol stops flowing through the mask. So those are our red flags. So from Therapeutics 1, you know that this is not meeting his demands. He's not getting enough from this. So he is in training room air, which is going to decrease his FiO2. Anytime that you see the aerosol stops flowing through the mask, you know that they are breathing too hard. You want to see this mist, and we'll go over this in the lab, that you'll be able to see the mist come out of the tubing. So if you have a low flow system, you know that you want to choose a high flow aerosol generator. So that would be the Misty Ox. So you just need to increase his flow. So don't let something like this that looks intimidating, don't overthink it. If you know he's on low flow, then you just need to help give him that little bump up. So you're going to want to increase to a higher flow.